This video lecture explains a structured, stepwise approach that helps narrow diagnosis logically rather than memorizing lists. So, systematic, exam-oriented and reporting-based approach for the diagnosis of bone tumor, which is based on the location, zone of transition, periosteal reaction, matrix mineralization, soft tissue component and role of CT and MRI. So in this video, we will use a step-by-step imaging framework to distinguish aggressive from non-aggressive lesions and narrow the diagnosis confidently. Why a systematic approach is needed for the diagnosis of bone tumor? So always emphasize that radiology diagnosis is based on correlation of clinical age, bone involved and imaging behavior. So before jumping to the diagnosis, see for these points. So many bone tumors look similar on X-ray, like we can see in this image. All tumors are appearing similar. So diagnosis depends on age, location of lesion and aggressiveness of the lesion. So same appearing lesion could not be so the same diagnosis. In this video, systematic approach for the bone tumor diagnosis is divided into the different stages. So step 1 is the age of the patient. So first see for the patient's age. Prevalence of bone tumor seen as given in this is less than 10 years simple bone cyst or Langerhans cell histiocytosis, Ewing sarcoma. So these tumors are common in less than 10 years, whereas in 10 to 20 years age, osteosarcoma, Ewing sarcoma and aneurysmal bone cysts are common. And in 20 to 40 years of age, giant cell tumor and chondroblastoma are more common. And in more than 40 years of age, metastasis is the more common malignant lesion or bone lesion as compared to the primary, and the multiple myeloma and chondrosarcoma are after the metastasis. So these are the tumors seen in different age group of patients. Now step 2 is bone involved. Certain tumors have predilection for specific bones, like axial skeleton's involvement is suspicious for metastasis in elderly patients. Certain tumors have bone predilection as around knee, osteosarcoma and GCT are more common. In pelvis and ribs, chondrosarcoma are more common. In spine, metastasis, multiple myeloma and chordoma are more common, whereas in hands and feet, enchondromas are more common. We can see that in skull there is eosinophilic granuloma, metastasis and multiple myeloma are common. In mandible, adamantinoma, dentogenic cysts are common, whereas in humerus, all kind of bone tumor, but simple bone cyst has more predilection in humerus than other bones. Ribs, metastasis, enchondroma, chondrosarcoma and Ewing sarcoma. In spine, metastasis, myeloma, osteoblastoma, chordoma, hemangioma, aneurysmal bone cyst and osteoid osteoma. So spine is more prone to the bone tumors. Pelvis, osteosarcoma, chondrosarcoma, simple bone cyst, lymphoma, Ewing sarcoma, eosinophilic granuloma and chordoma. Distal radius is more prone to the GCT and eosinophilic granuloma, whereas the hands are the enchondroma. Proximal femur shows predilection for the simple bone cyst, fibrous dysplasia, enchondroma, Ewing sarcoma and eosinophilic granuloma. And around knee, all type of bone tumor can be seen, but osteosarcoma and Ewing sarcoma are more common. In tibia shaft, non-ossifying fibroma, fibrous dysplasia, adamantinoma, osteoid osteoma are more common. In calcaneum, simple bone cyst, Ewing sarcoma, osteoblastoma and chondroblastoma are more common. Now step 3 is location within the bone. So previously we have seen that in step 2, bone involved, now the location within a bone. So first is the epiphysis. So tumors seen in epiphysis are the GCT and chondroblastoma. These tumors are more common in epiphyseal region. Then metaphysis. In metaphysis, more common are the osteosarcoma and aneurysmal bone cysts, whereas the surface lesion are the periosteal osteosarcoma, and in diaphysis, more common are the Ewing sarcoma and Langerhans histiocytosis. So these are the tumors which are more common in the different part of the bone, like epiphysis, metaphysis, surface lesion and the diaphysis. This image is showing the relation of age with bone tumors in different part of the bone. So this is the relation with the age and different part of bone, that is epiphysis, metaphysis and diaphysis. So this is comparison between the less than 30 years and more than 30 years. So in less than 30 years, that is the most common is in epiphyseal region is the chondroblastoma and infection are the more common, and whereas the meta epiphyseal region is showing the osteosarcoma more common, and in metaphyseal region is enchondroma, aneurysmal bone cyst, eosinophilic granuloma, simple bone cyst and osteochondroma. So these are the metaphyseal lesions, whereas the metadiaphyseal region showing the non-ossifying fibroma, chondromyxoid fibroma and osteoid osteoma. So these three tumors are the located in metadiaphyseal region, whereas the completely diaphyseal lesions are the fibrous dysplasia, Ewing sarcoma. So Ewing sarcoma is the malignant lesion, eosinophilic granuloma and ossifying bone lesions. So these are the diaphyseal lesion, whereas in more than 30 years of age, epiphyseal lesion is more common is the giant cell tumor. So this is the more common giant cell tumor. So metaphyseal lesion are the enchondroma, chondrosarcoma, metastasis and multiple myeloma. So metaphyseal lesion are the these four, and the diaphyseal lesions are the metastasis, multiple myeloma and lymphoma. So these three are the more common in diaphysis. Now step 4 is the zone of transition. So after the location within a bone, zone of transition is the step 4. So what is zone of transition? It is the junction between the tumor and the normal tissue. So it is the junction of tumor and the normal tissue is called the zone of transition. So narrow zone of transition is sharp margin. So this shows the sharp margin, and this is mostly seen in the benign lesion, whereas the wide zone of transition, that is the ill-defined margin, shows the aggressiveness or malignant lesion. In this image, we can see that the first image showing the narrow zone of transition, we can see that there is a thin margin, thin and sharp margin. We can localize the margin of the lesion. This is the margin of lesion. So this is the narrow zone of transition, whereas in this image we cannot visualize all the margin. We can see here but not visualize in this region. So we cannot say the where is the margin of lesion in this region. So this is the wide transition zone. So this shows the lesion is aggressive and mostly seen in the malignant lesions. So depending on the age and the zone of transition, so this is the well-defined lesion, ill-defined lesion and sclerotic lesion. In 0 to 10 year of age, eosinophilic granuloma and simple bone cyst shows the well-defined margin. Lesion is well-defined and margin is sharp, narrow zone of transition. Whereas in less than 10 years, ill-defined margins are the eosinophilic granuloma, Ewing sarcoma, osteosarcoma and leukemia. So these lesions shows the ill-defined margin, that is the wide zone of transition. So these are the malignant lesion, whereas the sclerotic lesions are the osteosarcoma. So in osteosarcoma, sclerotic lesion can be seen. We can see here that there is only margin is bright, whereas the whole lesion is bright in this image. So in 10 to 20 years of age, so non-ossifying fibroma, osteoblastoma, fibrous dysplasia, eosinophilic granuloma, simple bone cyst, aneurysmal bone cyst, chondroblastoma and chondromyxoid fibroma. So these lesions shows the well-defined margin. So these are the benign lesions, whereas the ill-defined margin seen in the Ewing sarcoma, eosinophilic granuloma, can show both well-defined and ill-defined margin. Whereas the osteosarcoma also shows the ill-defined margin, that is the wide zone of transition. Whereas the sclerotic lesion in 10 to 20 years seen the osteosarcoma, fibrous dysplasia, eosinophilic granuloma, osteoid osteoma and osteoblastoma. So this is due to the matrix calcification, sclerotic lesions seen. So these are the causes of sclerotic lesion in 10 to 20 years of age. In 20 to 40 years of age, well-defined lesions seen in the giant cell tumor, enchondroma, chondrosarcoma. So this is in low grade chondrosarcoma, and brown tumor and osteoblastoma. Whereas ill-defined margin seen in the giant cell tumor in. So giant cell tumor can show both well-defined margin and ill-defined margin. So ill-defined margin is seen in the malignant transformation of GCT. When there is a malignant transformation, then ill-defined margin is seen. And sclerotic lesion again seen in the enchondroma, osteoma, bone island, periosteal osteosarcoma, healed lesions like NOF, eosinophilic granuloma, simple bone cyst, aneurysmal bone cyst and chondroblastoma. Whereas in 40 plus years, metastasis can show well-defined margin, whereas it is malignant but it can show the well-defined margin. Multiple myeloma shows punched out margin or well-defined margin, and geode. So degenerative lesion can show the well-defined margin, whereas the ill-defined margin can be seen in metastasis and myeloma. So ill-defined margin is more common in metastasis and myeloma, and sometimes it can show the well-defined margin. This belongs to both well-defined and defined margins. And chondrosarcoma, so high-grade chondrosarcoma shows ill-defined margin. So whereas the low-grade chondrosarcoma can show the well-defined margin, whereas the high-grade shows the ill-defined margin. And sclerotic lesion can be seen in the metastasis and bone island. In all age group, infection can show both well-defined or ill-defined margin, whereas the healed infection can show the calcification. Now, step 5. In step 5, we can see that the pattern of bone destruction. What is the bone destruction? So, tumor cause the different type of bone destructions like geographical bone destruction, that is the benign. We can see that this kind of bone destruction, that is the benign. Moth eaten, that is aggressive. Here we can see that the moth eaten. And permeative bone destruction. So this is the permeative bone destruction. So this is highly malignant. Now the pattern of bone destruction. Now the pattern of bone destruction classified by the Ludwig. So depending on the pattern, it is divided into the 1A, B and 1C and 2 and 3. So there are 3 grades. So grade 1 is the benign. So this is the geographical pattern. This suggests the slow growing tumor. So this is the benign behavior or less aggressive behavior. So in grade 1 there is a sharp margin. We can see here is the sharp margin with sclerotic rim. So we can see here that is the there is sclerotic rim. So this is the very benign lesion. It is the benign lesion and it is seen in the simple bone cyst, non-ossifying fibroma and fibrous dysplasia. Whereas in the 1B, in 1B we can see that there is a sharp margin but there is no sclerotic rim. So this is also a slow growing tumor but it is more aggressive than this grade 1A. So examples are the GCT and enchondroma. Here we can see that the 1B well-defined lesion without sclerotic margin. We can see here there is a 1C. In 1C there is ill-defined margin and geographical lesion. So there is ill-defined geographical type of bone destruction without sclerotic rim. So this suggests that the lesion is more aggressive or maybe malignant. So examples are the low-grade osteosarcoma and infection. So its DD is also the infection. Whereas in the grade 2, here 2 are the grade 2. In grade 2, multiple irregular poorly defined as we can see here, multiple irregular poorly defined. These are the multiple irregular poorly defined lucencies noted in the bony lesion. So these are the most eaten type of bone destruction, and these are the aggressive lesions seen in metastasis, lymphoma, multiple myeloma, Ewing sarcoma, and acute osteomyelitis. So this can be also seen in the infection other than malignant lesion. Whereas the another is the permeative type of. So grade 3 is the permeative type. Permeative type appear as the numerous tiny lucency. So it looks like the worm-eaten appearance. So we can see these are the tiny lucencies, worm-eaten look. So these are the very aggressive lesion, and they are malignant lesions. They can be seen in Ewing sarcoma, lymphoma, leukemia, and metastasis. So these are the different grade of the bone destruction classified by the Ludwig, that is the grade 1. So one is divided into the 1A and 1B and 1C. So one is divided into the 3, and then grade 2 and grade 3. So grade 1 is the less aggressive lesions, more benign lesions, whereas the grade 2 is aggressive lesion and grade 3 is the highly aggressive lesions. Now step 6. In step 6 we know that the matrix mineralization. In step 5 we have seen that the pattern of bone destruction. Now the matrix mineralization. So there are three types of matrix mineralization: osteoid matrix, chondroid matrix, and fibrous matrix. In osteoid matrix it appears like the cloud. So it is mostly seen in the osteosarcoma, whereas the chondroid matrix appear as the rings and arcs. So it is seen in the chondrosarcoma, and fibrous matrix is ground glass appearance. So it is seen in the fibrous dysplasia. We can see here this is the osteoid matrix. So it appears like the cloud, whereas the chondroid matrix appear as the arcs and rings. So we can see here. So this is commonly seen in the chondrosarcoma, and fibrous matrix appear as the ground glass. So we can see here also this is the ground glass matrix. So this is seen in the fibrous dysplasia. Now the step 7. So in step 7 we see for the periosteal bone reaction or periosteal reaction. So periosteal reaction depends on the speed of the growth of the lesion. It depends on the growth of the lesion. So solid type of periosteal reaction is the benign, as we can see this image. So this is seen in the benign lesion, whereas the sunburst type or speculated type seen in the highly aggressive tumor like the osteosarcoma, and in sunburst type there is a Codman triangle. So this is due to the highly aggressive tumor. Onion skin is due to the lamellated type of periosteal reaction, that denotes that the different age of growth of the lesion. So this is also due to the aggressive lesion, but it is less aggressive than this Codman or speculated or sunburst type of periosteal reaction. So this is seen in the Ewing sarcoma. So this is called the onion skin periosteal reaction or lamellated periosteal reaction. Now step 8 is the soft tissue component or soft tissue involvement adjacent to the bone tumor. So soft tissue component is better assessed on MRI and then CT, but it is less accurately visualized on X-ray. So large soft tissue mass with minimal bone destruction is seen in Ewing sarcoma, whereas the calcified soft tissue mass is seen in the osteosarcoma. As we can see in this image, this is the X-ray image showing that this is the bone lesion. These are the periosteal reaction. These are the periosteal reaction, and this is the soft tissue component. These are the soft tissue component adjacent to the bone lesion. This is the soft tissue component, and this is better visualized on this MRI image. This is the soft tissue component, and this is the bone lesion. This is the X-ray showing calcified soft tissue component. Now step 9 is the role of MRI in bone tumor diagnosis. So MRI visualize the bone marrow involvement and neurovascular encasement. So this image showing the bone tumor with the marrow involvement Here we can see that the marrow involvement, and this is the also soft tissue component. Here we can see that there is neurovascular involvement. Now we can also see in the MRI skip lesions like in osteosarcoma, and by the help of MRI we can do surgical planning for the resection of the bone tumor. In this table we can see that the CT and MRI good for the diagnosis of bone tumors. CT is best for the cortical evaluation and the matrix mineralization, whereas the MRI is best for the marrow and soft tissue evaluation or extension. So cortical detail and matrix mineralization is excellently seen in the CT, whereas the poor in MRI, whereas the marrow involvement and the soft tissue extension is excellently seen in the MRI and it is poor for the CT. And local staging is done by MRI. So for local staging, gold standard is the MRI. So this should be remembered that the CT is good for the cortex and matrix evaluation, whereas the MRI is good for the marrow and soft tissue evaluation, and MRI is gold standard for the local staging of bone tumor. And for biopsy planning, MRI is best or better than the CT. MRI is better for evaluation of bone tumor than the CT, but in calcified lesion or calcifying tumors, CT is better than the MRI. Now the step 10, single versus multiple lesions. Multiple lesions are seen in the metastasis, multiple myeloma and Langerhans cell histiocytosis. As we can see in this MRI, we can see that the multiple lesions and skip lesion can be visualized very precisely, and single lesion can be seen in the primary bone tumors. As we can see here, there is a sunburst type of periosteal reaction seen in this X-ray. So this is the single lesion seen in the mostly in the primary lesions. Now for the exam scenarios, teenager with metaphyseal lesion and sunburst type of periosteal reaction. So this is the osteosarcoma. As we can see in this image, this is the sunburst type of periosteal reaction with Codman triangle. So this is the Codman triangle. So this signifies that this is the very aggressive type of bone tumor, and location is this is the metaepiphyseal region. So this is the osteosarcoma. Now the diphyseal lesion with onion skin type of periosteal reaction. So this is the Ewing sarcoma. As we can see here, this is the onion skin type of or lamellated type of periosteal reaction seen in the diphysis. So this is the diphysis. So location and type of periosteal reaction so suggest that this is the Ewing sarcoma. Now the epiphyseal lytic lesion in adults. So this is the lytic lesion. So this is the GCT. Elderly patient with punched out lesions are the multiple myeloma. As we can see here, there are multiple small punched out lesions. So these are the multiple myeloma. Now these are my references. If you like my video, then like, share and subscribe. Thank you for watching.